This video examines preclinical Alzheimer's disease, focusing on the silent brain changes that occur years before clinical symptoms emerge. We will cover early molecular pathology, neuron loss, atrophy, and delayed symptoms, intended for pharmacy and biomedical study. Our learning roadmap defines preclinical AD as a biological change without clear clinical symptoms. We will trace the sequence of pathology, understand the delay in symptoms, and connect silent pathology to future risk and prevention strategies. Preclinical AD is measurable Alzheimer-type pathology in people with normal daily function. This phase is typically detected by research biomarkers, signifying a risk state. Pathology is present, starting with amyloid, followed by tau abnormalities, while daily function remains preserved. The long silent timeline of AD shows that biological changes begin years before diagnosis. Silent pathology gradually reduces the brain's reserve capacity. The transition to mild cognitive impairment depends on pathology burden and resilience. This window is crucial for prevention studies. Amyloid beta peptides misfold and aggregate into extracellular plaques, often the earliest detectable biological signal. However, amyloid alone doesn't explain all symptoms, and may create a permissive environment for tau spread and synaptic stress. Tau is more closely linked to neurodegeneration. Abnormal phosphorylated tau disrupts neurons and spreads through connected regions. Tau burden tracks neuronal dysfunction and cognitive decline more closely than amyloid alone. Higher tau plus neurodegeneration increases clinical risk. The cortex and hippocampus are key brain regions affected. Amyloid is found broadly in the neocortex early on. Tau injury often affects the medial temporal regions, like the hippocampus, impacting learning and memory. Association cortex involvement contributes to difficulties in language, attention, and planning. Alzheimer's pathology spreads unevenly through brain networks. Vulnerable networks show altered connectivity. The spread is a network process driven by molecular pathology. The clinical profile depends on which circuits lose function first, progressing from the cortex to global symptoms. Synapses are vital for learning and memory. Amyloid, tau, inflammation, and oxidative stress can impair synaptic signaling before neurons die. Early synaptic loss explains why brain function declines before major structural shrinkage. Protecting synapses is a key therapeutic goal. Sustained pathology leads to neurons losing connectivity and balance. Neuronal death reduces the number of functional circuits. Neuron loss is difficult to reverse, making early detection crucial. The final pattern of cell loss shapes the individual symptom profile. Brain atrophy, or structural shrinkage, results from the loss of neurons and synapses. MRI detects atrophy via smaller hippocampal volume and cortical thinning. Atrophy is part of neurodegeneration and reflects accumulated injury, requiring context with age and other biomarkers. Symptoms are delayed because the brain has cognitive reserve, leveraging education and redundant pathways to mask early injury. Symptoms appear when compensatory mechanisms fail, and pathology crosses a functional threshold, creating a mismatch between biological disease and clinical diagnosis. The ATN framework classifies biomarkers into amyloid pathology A, tau pathology T, and neurodegeneration N. This system describes the biological state of Alzheimer's disease before symptoms. Combining A, T, and N provides stronger risk information, but clinical assessment remains essential. Amyloid PET imaging uses tracers to detect amyloid plaques, showing elevated amyloid burden. It identifies amyloid pathology in cognitively unimpaired individuals for research. A positive scan supports biological AD pathology, but PET interpretation requires clinical context and is not a standalone diagnosis. Tau PET imaging maps regional tau accumulation, correlating with neurodegeneration and cognition. Tau patterns help estimate disease stage and vulnerable brain networks. While tau signal may be limited in preclinical AD, it becomes more informative as pathology spreads. Tau PET is a specialized research tool. Structural MRI measures hippocampal volume loss and cortical thinning, revealing downstream brain injury. Serial MRI is useful to monitor the rate of tissue loss. MRI also detects non-AD contributors like strokes or vascular disease. FDG-PET estimates glucose metabolism, a proxy for neuronal activity. Reduced metabolism, or hypometabolism, in AD often shows in temporoparietal and posterior cingulate regions. This metabolic change can indicate network dysfunction before atrophy is extensive. Cerebrospinal fluid, or CSF, biomarkers reflect amyloid and tau changes. Common markers include A-beta-42, or the A-beta-42/40th ratio, total tau, and phosphorylated tau. CSF biomarkers can detect biological change early, and the ATN framework helps classify this evidence. Blood biomarkers are a rapidly advancing area. Tests for phosphorylated tau, amyloid ratios, and neurofilament light are improving for triage and confirmation. While promising, They require validated cutoffs and clinical context interpretation, and are not a replacement for neurological assessment. Microglia are immune cells reacting to injury and protein aggregates. Early inflammation may protect, but chronic activation causes synaptic and neuronal damage. This interaction with amyloid, tau, and vascular risk makes neuroinflammation a key target for research in preclinical AD. Vascular and metabolic factors, such as hypertension and diabetes, reduce brain resilience and may exacerbate AD pathology. Managing cardiovascular risk is a practical prevention strategy, supporting brain reserve across the life course, regardless of amyloid status. The APOE epsilon 4 allele increases AD risk and is associated with earlier amyloid accumulation. However, genetic risk is not destiny. Rare autosomal dominant mutations cause early onset familial AD but are uncommon. Genetic information requires counseling due to its impact on risk perception. The transition from preclinical AD to mild cognitive impairment, or MCI, is subtle, potentially starting with memory or word finding inefficiency. MCI involves measurable decline with preserved independence. Clinical follow-up uses cognitive testing, function review, imaging, and biomarkers. Early detection offers the benefit of identifying elevated risk before major irreversible neurodegeneration. A key limit is the uncertainty of predicting individual timing, especially in asymptomatic people. Ethical use demands informed consent, counseling, privacy, and access to follow-up care. Approved anti-amyloid antibodies target early symptomatic AD and are not routine treatments for asymptomatic preclinical AD. Treatment requires confirmed amyloid pathology and monitoring for ARIA risk. Preclinical trials aim to delay symptom onset, highlighting the importance of early diagnosis. Preclinical AD clinical trials enroll cognitively normal people with elevated amyloid or genetic risk. Outcomes include biomarker and cognitive changes over long follow-up periods. The challenge is that participants may remain symptom-free for years, but the goal is to test for long-term cognitive preservation. In a case example, a 67-year-old with normal function has a positive amyloid biomarker, but low tau and no atrophy. This indicates elevated biological risk without clinical disease. Next steps focus on counseling, risk factor control, monitoring, and considering research options. Preclinical AD is an integrated cascade involving protein misfolding, inflammation, synaptic dysfunction, neuron loss, and atrophy. Biomarkers map different cascade levels, so combined interpretation is strongest. Clinical symptoms appear late compared with the early biological changes.